So, Assalamualaikum warahmatullahi wabarakatuh and a very good morning, everyone. My name is Alwani, a medical officer in the Infection Control Department. And today I will be presenting on how we break the chain using multimodal hospital environmental hygiene, HEH, strategies in combating the transmission of MDRO, particularly MDR Acinetobacter baumannii in our ICU. So this is the outline of my presentation today. We will first start with MDRO epidemiology globally and in Malaysia, as well as how MDRO is transmitted in the healthcare setting. Then we will share our experiences in implementing the multimodal HEH strategies in reducing MDRO transmission. And we are also going to discuss on the barriers and challenges identified and how we overcome them. And finally, we will discuss the actions we've taken and our future plans to ensure long-term sustainability of this program. Okay, so MDRO is resistant to one or more classes of antimicrobial agents, and it is commonly causes infections in critically ill, immunocompromised patients or requiring invasive medical devices such as those in ICU. According to the CDC antibiotic threat report released in 2019, 5 pathogens, including carbapenem-resistant Acinetobacter and carbapenem-resistant Enterobacterialis, were listed as an urgent threats, with 11 were serious threats and 2 were concerning threats, emphasizing the growing danger of these infections, as we know that MDRO are difficult to treat, thus prolonged length of stay, which leads to increase in morbidity and mortality. Globally, the MDRO prevalence appears to vary between continents, where Asia reported the highest prevalence of ESBL Enterobacterialis and CRE Enterobacterialis, and it is also mentioned in the study that Asia has the lowest prevalence of ERE. Citing the Malaysian Infection Prevention and Control and AMR Containment Program report in 2023, we would like to highlight that multidrug resistant Acinetobacter baumannii is reported as the most prevalent multidrug resistant organism and has been responsible for numerous outbreaks in Malaysian hospitals, followed by ESBL Klebsiella pneumonia and CRE. Now let's recap on how MDRO transmission may occur in between patients. MDRO can be transmitted between patients in several ways. One, when healthcare workers or visitors come into direct contact with an infected or colonized patient, they can transfer the organisms to another patient, especially if hand hygiene is not properly maintained. And 2, via indirect contact, where these pathogens can survive on surfaces and medical equipments. Thus, when patients come into contact with contaminated environments, they can acquire the organisms, especially when these equipment and environment are not properly cleaned. Stressing on environmental contamination, especially on high-touch surfaces, it is known that several important pathogens such as MRSA, VRE, and Acinetobacter may be transmitted due to long survival times in the environment. Like example, multidrug-resistant Acinetobacter can last up to 5 months in the environment and increase the risk of acquisition to other patients. Speaking of risk of acquisition of MDROs, one paper did highlight on the risk of MDRO acquisition from prior bed occupants has shown that the likelihood of patients whose prior bed occupants were colonized or infected with gram-negative MDRO were 2 times more likely to acquire MDRO, where the risk may be due to poor clearance of the MDRO, leading to MDRO patients and contaminated environment to become the reservoir and source of further transmission. Before we go further into the interventions, we would like to show our baseline hospital-acquired MDRO infection rates in ICU from 2018 to 2020. And as you can see here, the most prevalent MDRO is multidrug-resistant Acinetobacter baumannii with around 4 to 6 per thousand patient days, followed by CRE and also multidrug-resistant Pseudomonas aeruginosa. In view of this, we perform a retrospective analysis of MDR Acinetobacter baumannii outbreak management in general adult ICU since 2020, where our hospital GICU is a 25 single room beds with 100 to 120 admissions per month and 5 to 600 patients stay per month. And initially, declared outbreak of MDR Acinetobacter baumannii outbreak in June 2021, which coincided with our COVID-19 pandemic in Malaysia. And our intervention started in June 2021 with our main aim is to reduce and stop multidrug resistant Acinetobacter baumannii transmission and also other MDROs in the ICU using the multimodal hospital environmental hygiene interventions. As hospital-acquired multidrug-resistant Acinetobacter baumannii is the most predominant MDRO in the ICU, we noticed that the hospital-acquired MDR Acinetobacter outbreak in the ICU, as you can see in the orange line, in UMMC coincided with the peak of COVID-19 in Malaysia, which is in the blue line. Now, we would like to introduce our existing hospital-wide IPC practices and programs since 2018. We have IPC policy and guidelines in place which includes hand hygiene, PPE, environmental hygiene, and transmission-based precaution, and these documents are readily available in UMMC staff portal. We also provided education and training to clinical staff, including contract staff such as food handlers and cleaners for both new and existing staff regularly. And we have also initiated isolation precaution for MDRO patients with signages at the patient area to ensure compliances to IPC practices. Next, since 2018, the Infection Control Department has conducted various surveillance and audit, including but not limited to the hand hygiene audit 2 monthly, PPE audit also to be done at 2 monthly, environmental hygiene, MDRO surveillance monthly, and also CBC care bundle compliance audit and BSI surveillance for every month. Since 2018, we also implemented ICU-focused infection prevention and control interventions, such as universal skin decolonization using chlorhexidine 4%, active screening for CRE and MRSA for all patients admitted to ICU, including targeted nasal MRSA decolonization. However, despite the IPC practices and program in place, unfortunately, we had a multidrug-resistant Acinetobacter baumannii outbreak in June 2021 with a rate increase from 6 per 1,000 patient days to 17.5 per 1,000 patient days in June 2021, prompting us to officially declare an MDR-AB outbreak in the ICU. Once outbreak was declared, we performed a gap analysis in order to identify the missing elements and discrepancies in our practices. So we highlighted a few issues such as one, environmental cleaning audit, especially on the high touch areas, dropped down to 60%, where the KPI must achieve 85% and above. The gap we identified was the environmental service staff are not properly trained. And next one, there's lack of interdisciplinary communication, which leads to delays or breakdowns in communications and lack of coordinated response plan, where we should be having a clear, timely communication channels for all stakeholders. And thirdly, there was a breach in infection prevention and control practices, especially in PPE and hand hygiene, due to COVID-19 pandemic, where we face a lot of misunderstanding on IPC practices such as hand rub on the gloves and use of PPE, and they were bogged down due to COVID-19, where continuous education and training should be done, especially to ICU staff to address all these issues. So what are the early interventions that we did in order to stop the transmission? One, we call up all the stakeholders such as nursing department, ICU team, infection control, and environmental service team for a team meeting. And we address the issue and discuss on the actions to be taken in order to stop the transmission. Secondly, we retrain and re-educate on PPE and hand hygiene for all ICU staff. However, despite the early interventions, the cases continued to increase. We reviewed multiple studies and evidence-based practices, and we decided to implement the multimodal hospital environmental hygiene strategies based on WHO, which consists of 5 key components, which is build it or system change, teach it or training and education, check it, which is monitoring and feedback, sell it, which is a reminders and communication, and live it, which is culture change. Firstly, system change. We look into various guidelines and studies on hospital environment cleaning approach and technique. We compared on the choice and product used for cleaning and disinfection. As you can see here, we use chlorine-based disinfectant tablets. We also emphasize on what are the equipment used for cleaning such quantity such as quantity of the pills for wiping, type of mop, and many more. We also look into cleaning techniques, one wipe, one side, one direction, and also S-shaped wiping or mopping. In order to ensure the right solution concentration, we also perform chlorine dilution testing. And lastly, we updated our hospital environment cleaning guideline and incorporate all these approaches and technique in our hospital guideline. Secondly, training and education, not only for the clinical staff, but also the environmental service staff. We developed a standardized training module on hospital environmental hygiene, which consists of teaching slides, not only on cleaning approaches and techniques, we also put in IPC measures for them to follow and training videos, all in Bahasa Malaysia. Next, we conducted a 2-day hospital environmental hygiene train-the-trainer to the cleaning supervisors, which consists of day one face-to-face lectures. We find it much easier to address any doubts and questions from the supervisors of different education and literacy background. And in the afternoon, we usually have the demo session on cleaning. The next day, we done our competency assessment for the supervisors assessed by all the infection control nurses to ensure that this environmental service staff will get the same info and only competent EBS will teach the other cleaners. And we also provided a certificate of competency for the supervisors who passed the assessment. Then the trained supervisors taught all the other cleaners through group sessions and one-on-one session in their working station. Next, for check-it or monitoring and feedback, we have developed a standardized environmental audit form based on our guideline consisting of 3 audit forms and checklists. The IPC environmental cleanliness audit form, which used to assess the overall cleanliness of the area, the environmental cleaning checklist, which is utilized not only by the infection control nurse, but also by the ICU link nurse to audit cleaners, ensuring they use the correct methods and techniques to clean the area, and the high touch surfaces audit form where the ICN randomly applies, ICN randomly applies fluorescent markers on high-touch surfaces and equipment according to the checklist. In the feedback component, we actively involve what staff as auditors, allowing them to provide direct feedback to the environmental service staff. The link nurse also shares audit findings and feedback with our infection control nurse, and these insights are then shared with the rest of the ICU team and discussed during our weekly AMS and IPC rounds. And additionally, we have this MDRO board in ICU, ensuring all ward staff are aware of any rise in cases so that prompt action can be taken. Next component is silent or reminders and communications, where in the wards utility room, a board displays reminders about daily tasks and solution dilution instructions. Additionally, we have posters and reminders on hand hygiene placed near the sinks, including notices to avoid disposing of body fluids in the hand washing sinks to minimize environmental contamination. And we also put on reminders posters about limiting the number of individuals in isolation rooms to prevent contamination. Next, communication was enhanced not only between the EBS and infection control team, but also between the ICU staff. We initiated quick communication through a dedicated WhatsApp group and established regular meetings with the EBS management to address any issues related to the environmental clean. Lastly, we focus on fostering a safety climate and driving cultural change within the area as part of patient safety efforts. The ICU team established a patient safety team, appointing champions from various job categories, with the UMHealth deputy director serving as one of the members. And as a part of critical care community, we also presented findings on MDRO, hand hygiene, and other audits during the meetings, including the critical care subcommittee, which is also chaired by the UMHealth deputy director. And this is to aim to expedite any action and gain stronger support in addressing these issues. Additionally, in line with the service standards set by the MSQH, 100% of new staff and 85% of existing staff, including housekeeping staff, must complete the infection control training. So these standards have been integrated into our quality objectives to drive cultural change. We have just received our MSQH accreditation, and this support the institutions' initiatives in achieving our goal in reducing not only MDROs, but also HEIs. Other than that, we have also implemented additional environmental hygiene interventions such as scene cleaning protocol, with 3 monthly surveillance culture was implemented since October 2022, and we put in reminder posters advising them not to dispose any body fluids in the hand washing scenes, and we also initiated quarterly surveillance cultures to monitor for contaminations, 1,000 parts per million sodium hypochlorite, and any confirmed they were free of contamination. As a result, the percentage of contaminated sinks decreased from 39% in October 2022 to 4 to 8% in subsequent months. Next, UVC disinfection machine, which was first introduced in ICU as a part of adjunct terminal cleaning, where we developed a guideline on handling of the UVC disinfection machine, and training was conducted together with the Malaysian Nuclear Agency and also UMMC OSH team to the hospital attendants, and we believe that there's a lot to learn from this no-touch cleaning innovations. So with multimodal hospital environmental hygiene strategies, we have managed to reduce significantly our hospital-acquired multidrug-resistant Acinetobacter baumannii rate in the ICU from the baseline of 6 per 1,000 patient days to 23 per 1,000 patient days, and gradually decrease further to 5 per 1,000 patient days from October 2022 to December 2023. Over the years, the other hospital-acquired MDRO was also reduced with these interventions in 2023. With the implementation of multimodal strategies as well, compliance with cleaning high-touch areas has increased and consistently remained above the KPI, while hand hygiene compliance has been maintained throughout all periods. In conclusion, the implementation of multimodal hospital environmental hygiene strategies reduces MDROs while enhancing compliance with environmental cleaning and hand hygiene practices. And in one of the studies focusing on environmental cleaning bundle in multi-centered well-controlled study has shown reduction in gram-positive organisms. Similarly, the environmental multimodal strategies that we implemented in the real-life hospital setting managed to reduce not only multidrug-resistant Acinetobacter baumannii, but also other gram-negative organisms. So just a quick recap on the existing practices, hospital environmental hygiene interventions, and additional strategies that we implemented in our ICU in UMMC. And throughout our journey, we have identified lots of barriers and challenges, and some of the barriers and challenges are similar to those discussed in one of the papers, which titled Hospital Cleaning, Past, Present, and Future. The identified barriers and challenges include the devaluation of the EBS staff who often feel unimportant and at the bottom of the hierarchy. There are also communication barriers stemming from language differences, literacy level, and varying educational backgrounds. And additionally, there are issues related to availability of resources such as cleaning materials, staffing, and finally, there is a need for greater involvement and buy-in from key stakeholders to emphasize the importance of HEH initiatives. To tackle some of the barriers and challenges while ensuring the sustainability of the program, we celebrate and appreciate our EBS staff during the World Hand Hygiene Campaign. We presented our best environmental service staff award, and as you're in the photo and right, the award is given by our hospital directors actively engaged in and supportive of IPC activities. And to ensure sustainability, we organized a talk with Professor DDPT on clean hospitals, and the infection control team represented UMMC at a hospital environmental hygiene workshop in Malaysia held earlier this year, demonstrating UMMC's commitment to clean hospitals. And to further ensure sustainability, we also plan to make Clean Hospitals Day a yearly event beginning this year. And we just released our first newsletter last October. So feel free to scan the QR code to read more about the Clean Hospital, or you can check your email. Looking ahead, we are eager to explore additional environmental hygiene interventions, particularly no-touch cleaning methods such as hydrogen peroxide and UVC. We also seek to learn more about the environmental hygiene innovations, including the integration of electronic monitoring and feedback on cleaning with our electronic medical records, AI, and waterless ICU. And additionally, we plan to extend these multimodal strategies to other wards to reduce the MDRO and HAI, and aim to focus on behavioral change by educating healthcare workers and also incorporating implementation science to ensure sustainability. In summary, hospital environmental hygiene is crucial for the prevention and reduction of MDROs alongside other infection prevention and control interventions, such as hand hygiene, the use of PPE, transmission-based precaution, and also antimicrobial stewardship, AMS. It is time for cleaning, often referred to as the Cinderella of infection control, to step in the spotlight now. Just a quick one. This is me, Prof. Sasheela during EPSI, and we presented the same paper and won third place during EPSI Jakarta 2024. And lastly, we would like to thank the infection control team, the ICU team, and special mention to Prof. Azim and also Puan Pemuda, the matron and also head of in charge in ICU and ICU leaders, and the environmental service management team for the success of these interventions. And lastly, the same promotion like Dr. Helmi did just now, please kindly join us for our EPSIC 2026 in KLCC next year. Feel free to approach anyone from Infection Control Department or ID unit for further info. So with this, I thank you.
Thank you very much, Wani and Hilmi, for your excellent presentation, for your very insightful and thought-provoking presentation. There were many questions in the question and answer box. I think Hilmi has answered them. If anyone has any burning questions, you can put your hands up. If not, please type them down and we will try to answer them as much as we can. Also, before I end, just like Wani, I would like to thank the ICU team, the nursing team, facility and management for their efforts to improve IPC in UMMC and for the sake of patient and healthcare worker safety. So we always think we are protecting the patients, but actually we are protecting ourselves as well against multi-drug resistant organisms. So in view of time, I will end now. And before I end, I want to just say, dear Warga, UM and UMMC, thank you for staying with us. And as we observe World Antimicrobial Resistance Week, let us commit to using antimicrobials responsibly and adhering to infection prevention measures diligently in our daily practice. Together, we can make a difference in preserving the efficiency of antimicrobials for future generations and also for us. And wishing you all a prudent and impactful wow. Thank you.